All right. So I'm going to touch on treatment for metastatic and advanced prostate cancer. I know that you already had a panel that discussed different types of treatment, and I listened to most of Dr. Schrader's talk to see how much he talks about the genetics, because I just included a couple slides as I knew that there's going to be a longer talk on that. I have no disclosures to start with. And the objective of this talk is to talk about the current standard of care for advanced and metastatic prostate cancer, and then also touch on the future treatments that we see in the horizon. So as the cancer statistics, as you know, prostate cancer is the most common type of cancer in men. It includes 26% of all cancers that are seen in men, and it is the second most common reason for death from cancer. And the reason for that is because it's the most common type of cancer, almost a quarter of cancers in men is prostate cancer, so it also causes the second most common cause of death, which is 11% of cancer death. So around 1 out of 9 patients, 1 out of 9 men will develop prostate cancer sometimes throughout their life. If you look at the, again, trends in cancer mortality rate in the United States since 1930, this dark maroon line is prostate cancer down here. And when we look since 1993, there has been a drop in death rate by 2 to 3% per year in prostate cancer. You all know about prostate cancer specific membrane antigen, or PSA. Prostate-specific antigen, I'm sorry, or PSA. PSA is a biomarker that we have in the blood that we can easily look at prostate cancer and follow how it's basically growing, if it is. PSA is a very important biomarker, but I don't want patients to sweat on it based on the numbers, because PSA really, what matters is not what the number is. What matters most is how rapidly PSA is going up. So there is a term that we call as PSA doubling time, which means how long it takes for PSA to double in the number. And anything 10 months or less is what we get concerned about. There are different imaging tests that we use when patients are diagnosed with prostate cancer. So these imaging tests are used when we want to screen for prostate cancer, when we want to stage the prostate cancer, or when the PSA is going up or patient is having symptoms and we want to see where we are at from the prostate cancer standpoint. There's different types of imaging we use. There's conventional imaging, the nuclear bone scans, CT scans, different CT scans, MRI and PET-CT. And also we have the new molecular scans that have been around for the past few years. There's different molecular scans like PSMA PET scan, the fluciclovine F18 PET, which is what we have in New Mexico. It's the oxamine scan. There is C11 PET, and there is the sodium 18F scan. These are more accurate scans. They go based on molecular imaging, and they are more accurate in finding the spots that have prostate cancer cells. Why we do these scans? Because we want to see if the patient has metastasized, if the cancer has metastasized yet or not. The most common sites of metastasis in prostate cancer is bone and lymph node. Bone is usually in the pelvic or spine area where it's closer to the prostate, and lymph nodes is usually starts with regional lymph nodes, such as lymph nodes in the pelvic area. And then when the cancer progresses, it can also involve the internal organs, such as lung, adrenal gland, peritoneum lining, liver, and etc. So a couple slides on the genetic tests. The genetic tests are done, as Dr. Schrader mentioned, there are 2 types of genetic tests that we do. There is a germline testing, which is genetic test for looking for inherited cancer risk. That's either blood or saliva, and basically it looks at mutations or gene abnormalities that you inherit from your parents, and it can put you at risk of other types of cancer. or you can pass those genes to your children. And these are different genes such as the BRCA mutation, which can be seen in breast and ovarian cancer in women. It can be seen in colorectal cancers, in pancreas or melanomas. So if you have any of those types of genes, you should be aware and watch for the other cancers. The genetic counselor will explain to you how to screen for other cancers. And then if you have any of those, your children might want to also get tested. Not everybody needs to do the genetic testing for inherited mutations. The recommendation from NCCN is patients who are diagnosed with a very high or high-risk prostate cancer, patients who are diagnosed with a prostate cancer that has already involved the lymph nodes or bones at time of diagnosis, or other areas metastasized at time of diagnosis. Patients who have a very strong history of different cancers are recommended to get tested. Patients who have had prior cancers themselves, such as pancreas cancer, any cancer a syndrome in the family, like the Lynch syndrome, and some specific ethnicities are recommended to do the germline testing. And then we do have the biomarker testing, or what we call molecular testing for treatment planning. And that's when we take a piece of the tissue from the prostate cancer, whether it's the primary prostate cancer tumor or whether it's the site of metastasis. These biomarker testing or genomic profiling, or what we call, as Dr. Schrader said, precision medicine, is basically looking at specific genes. In every cancer, we look at different genes. In prostate cancer, we want to look at BRCA1 and 2, ATM, CHEK2, and PALB2. The reason for that is we have treatments that we have in patients with prostate cancer that have specific mutations in those genes. So it will open up more treatment options for our patients. There is microsatellite instability testing that if you have that, you can get immunotherapy or pembrolizumab. The best way to check for microsatellite instability is to do a next generation sequencing. And the incidence is really not that high in patients with prostate cancer. It's less than 5 out of 100 in patients with prostate cancer. And then we have the mismatch repair testing. So as you see, it's really a big team that takes care of patients with prostate cancer. The team includes a pathologist to start with that looks at your diagnosis of the biopsy or prostatectomy. We have the anesthesiologist that works with the surgeons, urologists, which is specifically trained to take care of cancers from urology. You have the radiation oncologist, medical oncologist, the interventional radiologist that would repeat your biopsies or sometimes would do cryoablation. We have the pharmacist that works with us when we start any patient on systemic therapy. When you're being seen by in a cancer center, you already know that you have advanced care providers in oncology. These are physician assistants or nurse practitioners that are trained to take care of oncology patients. They're the oncology nurses in the infusion and injection centers. We have genetic counselors. Not all of you might need a genetic counselor, but a lot of our patients should sit with them and go over the risks. We have a nutritionist and psychologists or psychiatrists that I feel like we are not using them as much as we should. I personally think every cancer patient should at least meet with a psychologist or a counselor at least once. And of course, on the top of all that, we have your primary care doctor that has a very important role in trying to take care of you as a whole while we are giving you all these cancer treatments to help us make sure that you are not having any of the, you are being monitored for a lot of these side effects of treatments. So moving on to the treatment, which is the main reason of this talk. The backbone of treatment, as again, you all know, it's androgen deprivation therapy. And that is because prostate cancer is driven by the male hormone or the testosterone. And the goal of androgen deprivation therapy is to get your testosterone levels to a level of less than 50, which we call a castration level. And androgen deprivation therapy, or what we call hormonal therapy, has a lot of side effects. It's not without side effects. The most common ones is fatigue and feeling tired and having hot flashes or sweats. Almost all patients experience some weight gain or breast enlargement. You'll lose your sex drive. And then there is other side effects like reducing your bone mass and heart disease. So although this is the backbone of treatment, we don't want to give it to you unless we have to give it to you. Well, this is basically the journey of a patient with prostate cancer. This is how the natural history is. It starts with a localized prostate cancer. And then at some point after definitive treatment, the PSA relapses and patient's disease burden goes up. The patient starts on hormone therapy usually, and then initially it's responsive, disease burden goes down, and then again it starts climbing up. And that's when we have to start trying different treatments and the cancer becomes metastatic. So this is a very condensed, I would say, table of different treatments of prostate cancer that are currently FDA approved. I put the local therapy here just because, although I'm talking about systemic therapy, I just wanted to make sure that we all know there's different types of local therapies, which even it includes active surveillance or just watching the patient and observing. So observing is when we are just watching without doing extra biopsies, and active surveillance is we are watching the patient and we're doing some interventions like annual or every 2-year biopsies. And then we have radiation, prostatectomy, cryotherapy, and high intensity focused ultrasound. All these other columns here are treatment for advanced prostate cancer. Some patients decide to do bilateral or orchiectomies in order to achieve a castration level of testosterone. Most patients decide to use medications for that. The most common medications used are GnRH agonists or antagonists. Those are injections that you receive, which includes like Lupron, Trelstar, Eligard, all those good injections. And then there are anti-androgens, and the last 4 down here are more novel hormonal treatments. Abiraterone or Zytiga is the treatment that basically blocks production of testosterone in the adrenal gland. Enzalutamide, apalutamide, and darolutamide are all androgen receptor inhibitors, so they block sitting of the testosterone on the prostate cancer cells. We do have chemotherapies. Docetaxel is the first-line chemotherapy, and cabazitaxel is used when patient's cancer has progressed after using docetaxel. Mitoxantrone is a chemotherapy drug that it does not improve how long you live, but it helps with symptoms. So if a patient cannot receive any of those other treatments for symptom management, that can help. Mitoxantrone can help. Then we have immunotherapy. CPT or Provenge is how they use your own cells to fight the cancer cells. It does not have extraordinary effects on your PSA response or radiographic response. It has some overall survival benefit. There is a group of medications that we call biomarker targeted therapy. Those are based on the gene testing, molecular profiling that we do on you. Olaparib and rucaparib are drugs that are from the class of PARP inhibitors. They basically cause DNA damage in the cells, and they are only approved in patients who have specific gene mutations. That's why I put the asterisk there. And pembrolizumab or Keytruda, it's a drug that is basically a checkpoint inhibitor immunotherapy drug. We could put it under the immunotherapy column also. It is approved in patients with prostate cancer that have specific biomarkers such as microsatellite instability. And then we have the radiopharmaceuticals with radium-223 or Xofigo, which again, it's only used in specific patients, specifically patients who have prostate cancer that has metastasized to the bone and it's painful in the bone. Patients should not have any metastasis elsewhere in their body, because the way this agent works, it goes only to the cells that are in the bone, and it only treats those. Again, you may not see a response in the PSA with Xofigo. You may not see a dramatic change in the imaging. So it's a little hard to figure if this cancer is responding to the treatment or not, but on the trials, we know that it improves survival. And I've also added lutetium PSMA 6117 here. The reason I added it is I'm pretty sure that it's going to get approved soon, and we'll touch base on that also. So I love this slide. I used it in my previous talk last year in prostate cancer. This is, I call it the battle of metastatic prostate cancer. It is very fortunate for our patients that we have so many drugs available now to treat their prostate cancer. It makes it harder for your physician sometimes to decide which drug to pick for you, but we have to go case by case. Every patient is different, and your physician decides how to treat you based on different criteria. This is a big picture of how your oncologist decides how to treat you. This is based on disease states. So if you have localized disease, you'll have different treatments that I didn't put here, but then based on if your PSA is only rising and there is no metastasis, if your PSA is rising, there is no metastasis, but your cancer is not anymore responding to hormone ADT therapy, or if there is metastatic disease and is still hormone sensitive, or is castration resistant, meaning not anymore responding to hormone therapy. So based on those, your oncologist decides which treatment to put you on. On top of that, your oncologist looks at other things when deciding to put you on what treatment. That depends on what prior treatments you have received, how old you are, what other medical problems, or as we call comorbidities you have. What is, if you have metastatic disease, what is the burden of metastasis, how much metastasis you have, which areas, which internal, if there is any metastasis in an internal organ, or it's only confined to the bone, how many spots there are, etc., etc. So there's so many things that your oncologist will look into before picking the right treatment for you. And we should never forget that best supportive care while you are getting cancer-directed care is very important. Radiation therapy to palliate pain from bone metastasis and sometimes for bulky lymphadenopathy is very helpful. These treatments with ADT cause osteoporosis, so you have to have bone-targeted therapy when you have a castration-resistant metastatic cancer. Bone-targeted therapies are treatments that prevent bone fractures and help with the bone pain. And now we are looking into a lot of combinations in treatments in addition to the ADTs. All these different class of drugs that we talked about, combination of all these different drugs together, 2 drugs or 3 drug combinations are being investigated. The most common ones that are being investigated is chemotherapy plus an androgen receptor targeting agent, immunotherapy plus an androgen receptor targeting agent or an androgen inhibitor. Targeted therapies such as PARP inhibitors are being investigated, plus immunotherapy drugs like pembrolizumab, or plus an androgen receptor inhibitor. Radioligand therapy is being tested with all of them, and the newer drug lutetium PSMA is being tested with androgen receptor inhibitor drugs. So there is just countless combinations that are currently being investigated. There has been multiple failed trials. But there are also trials that are looking into high-risk prostate cancer combining, and there has been good results from them. I touch on a few of the novel treatments. The 2 that I picked for the talk today, one of them is 177 lutetium PSMA 6117, and the other one is AMG 160, and we'll go for a few slides over those. So PSMA is something that you'll hear a lot these days in scans and also as treatment. PSMA stands for prostate-specific membrane antigen, which is basically a transmembrane protein that is expressed on prostate cancer cells. It is very highly expressed there, and it's even the expression goes up when the patients develop castration-resistant or they've been on androgen deprivation therapy for a while. So currently PSMA is a target to look for the PSMA PET scans and that they look at those cells and they identify those cells. But now we have learned how to use this protein in treatment purposes. So what we do is PSMA 6117 protein is tagged on a beta emitter, which is called 177 lutetium. So this makes a molecule, and then this molecule is basically taken up or eaten by the prostate cancer cells. And when it's inside there, it destroys the cancer cells and causes cell death. Let's see what time it is. I have a very short video on PSMA targeted therapy. I've taken this from Prostate Cancer Foundation of Australia. I'm gonna put a couple minutes of it because I think it really visualizes how this treatment works. I'm gonna forward a little bit, so.
New technology in PET scanning is revolutionizing the treatment of advanced prostate cancer. The first stage of the process uses a new high-tech approach to detect how far the patient's prostate cancer has spread. A radioactive tracer is manufactured by attaching a gallium-68 atom to a special molecule called a ligand. When injected into the body, the ligand attaches itself, like a key fitting into a lock, to a protein called prostate-specific membrane antigen, or PSMA for short, which is found on the surface of prostate cells. Up to 1,000 times more PSMA is found on prostate cancer cells, including prostate cancer that has spread to other parts of the body. The second stage of the process is treatment. This involves attaching a different radioactive atom to the ligand and injecting it into the patient's body. This new radioactive atom, lutetium-177, decays more slowly than gallium-68 and gives off a beta particle which kills the cancer. Doctors inject the lutetium ligand combination into the patient's body and it attaches itself to the cancer cells, where it begins to deliver the radiation. Beta particles only travel 1 millimeter, so they deliver high levels of radiation to the cancer cells, killing the cancer. The initial gallium-68 scan helps the doctors to determine the correct dose.
You can see that almost everything's back to normal. In fact, if we looked at this scan, it's hard to pick an abnormality. So all the tumours in the bones, but also the adrenal glands and the lungs have disappeared. And we can look at this in a variety of other ways. This is a slice through your body this way, and these are the tumours spread to the adrenal glands here in the red, with the liver and the body in the back.
All right, the rest of it, they keep talking about how cool this is, which we already learned. So this is a slide from a study in Heidelberg. PSMA treatment was pioneered in Heidelberg. If you see on the left image, these black spots are all spots from cancer. And this is from December of 2014. And after a few treatments with PSMA, this is a different PSMA treatment though. In 6 months, you see that all those spots have disappeared. This was in a patient that had received this on the left lower pane. You see the patient had already received so many other prior treatments. Now, not all patients develop such a miraculous response. This is such an amazing slide that in every talk with PSMA, because it's so miraculous, everybody uses it. However, it's very promising overall. The VISION trial is the biggest trial on PSMA targeted therapy, which looked at standard of care versus standard of care with lutetium-617 PSMA. And it was in patients who had already received at least 1 or 2 lines of treatment for treating their metastatic castration-resistant prostate cancer. The results of this study was reported in the ASCO meeting in June, which is the biggest meeting in clinical oncology in the world. And they showed that PSMA targeted therapy was well tolerated with this agent, and also showed that adding this treatment to the standard of care delayed radiographic progression, meaning spots that we see on the scans showed up later, and it's improved survival and patients lived longer. This is just a couple slides again showing the blue curve is showing patients who received lutetium PSMA-617, and the yellow or orange curve is showing the ones who received standard of care alone. And when the curve is higher, the patients live longer. So this shows that patients overall live longer with this new treatment. And also when you look at this, this is the secondary endpoint of the trial that was looking at the responses on the scans. The left blue bars, it's complete response, meaning every spot from metastatic disease that was measurable went away. And this one, this blue bar showing partial response. So you see that again, the orange ones are standard of care, the blue ones are PSMA lutetium treatment, and there were more complete responses and partial responses with the radioligand agent. A couple slides on the AMG 160. AMG 160 is still not as well investigated as lutetium 617. But this is a drug that Amgen is working on. It's a BiTE drug, basically, which is a bispecific T-cell engager immunotherapy. What BiTEs are BiTE molecules engage the patient's own T-cells to attack and kill the cancer cells. A type of BiTE therapy has been approved in, Blincyto has been approved in leukemias. And a specific BiTE therapy for prostate cancer is now called AMG 160, which is a specific type of BiTE immunotherapy for prostate cancer cells. The phase 1 has been done by Amgen. And these are the PSA results after BiTE therapy on the phase 1 trial. So trial on very small number of patients. And a good number of patients, their PSAs dropped into half. Everything down means good. And when you look, there was about 68% of patients had a decline in their PSA. So Amgen is working on second and third phase trial on this drug. So this is the treatment landscape of prostate cancer. As you see that there are different number of treatments that we use. We use chemotherapy, hormonal therapy, targeted therapies, radioligand therapy, and the treatments keep evolving as years go by. This is another slide to look at the timeline of FDA approvals of treatments for prostate cancer. As you see, in 1996, we didn't have any treatment that would improve how long patients live. And then in 2004 was the first time that a chemotherapy got approved that helped patients live longer. And then since 2004, you can see how dramatically this landscape of prostate cancer treatment has changed. And as you see, such as how treatments get approved, for example, abiraterone in 2011 was approved for patients with metastatic prostate cancer that had castration-resistant prostate cancer. And then as years went by, in 2018, it got approved in patients who were hormone sensitive, meaning that it was their first-line treatment when they became metastatic. And enzalutamide, if you look, also follows the same trend. Enzalutamide was first approved in the castration-resistant setting after patients' cancer had failed other treatments, and now it's in 2019, it was approved as a first-line setting. So as we know these drugs more, we try to use them early and earlier to help patients live longer, if possible. And then lutetium PSMA-617, given the very good results from the trial, we are expecting it to get approved sometime in the first quarter of 2022. FDA is currently looking into the data. Just a couple slides on how drug development works in different phases of research. In phase 1, it's a very small phase. We probably 10 participants, 10 to 20. The goal of that is to determine whether this new investigational drug is safe to give to the patients, is effective, and identify the main side effects. Then if it passes phase 1, it moves on to phase 2, which is a larger group of patients, 10 to hundreds of patients. And the goal of phase 2 is to further investigate safety and see how efficacious it is. And once the drug passes phase 2, it goes on to phase 3, which is in hundreds or thousands of patients. In prostate cancer trials, if it's a phase 3 trial, it's usually over 1,000 patients. And it looks to confirm the effectiveness, monitor side effects, and compare results with the standard care that we are using. So when the drug shows improvement of a lifestyle, improvement of how long you live, or improvement on how late cancer will metastasize, then FDA starts looking into approving it or investigating it. Here are a couple samples of trials that are national. They are run, sponsored by National Cancer Institute or NCI. These are 2 trials which are very much sister trials in localized prostate cancer. I know Dr. Schrader talked about one of them, the NRGGU-009. So basically, these 2 trials look at patients with different risk groups of prostate cancer. The goal of these trials is to try to identify which patients need less treatment, not 24 months of hormone treatment, as hormone treatments have so many side effects, or if patients have a very high-risk disease and need to get more treatment, such as combining androgen deprivation therapy with other androgen receptor inhibitors, or in patients with lower risk to make sure that they're not getting so we basically want to understand whether we are not over-treating or under-treating our localized prostate cancer patients. Here is a couple examples of trials in metastatic prostate cancer. The left trial is, these are again all trials that are sponsored by National Cancer Institute or the NCI. The left one is a trial that's looking in patients with castration-resistant prostate cancer that are metastatic. It combines the PARP inhibitor rucaparib plus androgen receptor inhibitor enzalutamide, which is standard of care, versus a group of patients that will get enzalutamide, which is standard of care, plus a placebo. So they want to see, we know PARP inhibitors are already, rucaparib is already approved in patients with prostate cancer that have the BRCA1 or 2 mutations. The thought is that even in patients who don't have those mutations, when we combine those drugs with androgen receptor inhibitor, it enhances the results, the efficacy. And even if a patient doesn't have those mutations, they can benefit from the combination. So this trial is looking into that. And then the other trial is looking at 177 lutetium PSMA 6117. It's looking at patients who have castration-sensitive prostate cancer. So it's a first-line treatment of a patient with metastatic prostate cancer, just like how abiraterone and enzalutamide were moved further upon diagnosis. Lutetium PSMA 6117 is being investigated. The trial puts patients into 2 different groups. One group receives standard of care alone with abiraterone, enzalutamide, or apalutamide, and the other group of patients receives standard of care plus the lutetium 6117. So both these trials, and this is how phase 3 trials are. One group of patients receive standard of care because obviously we don't want to undertreat our patients, but the other group of patients, which are in the investigational arm, receive standard of care plus an additional investigational treatment. I really like to hear feedback from our patients, from you as the audience, on what would make you decide whether you want to go on a clinical trial or not, how you feel about going on the investigational arm or going on an arm which has standard of care plus placebo, because those feedback help us design the further trials, future trials. I have to acknowledge our patients and families. Without them, none of these trials would be possible. The whole science, the field of science really owes our patients, because without them, nothing would move forward.
Yeah, we've gathered some questions here for you,
Mhm.
Doctor.
So I'm going to go over them. Dawn is asking, can one have PSA producing cancer and non-PSA producing cancer at the same time? Both are both responsive. So Dawn, definitely, the whole talk that I talked about is about the prostate adenocarcinoma, which is the most common type of prostate cancer. There is less common types of prostate cancer, such as a small cell prostate cancer that is very aggressive. It does not produce PSA, and it really doesn't respond to ADT. So it has to be treated with different types of chemotherapy that we didn't mention here. However, prostate cancer can be very heterogeneous, and sometimes there are different clones. It's prostate adenocarcinoma, but there are different clones of prostate adenocarcinoma. So there's some clones that are non-PSA producing. In all those patients, we still continue the ADT because we want to make sure that we are covering the PSA influence prostate cancer. So we never stop the ADT because there's always clones that are responsive to ADT. Jerry is asking, how much does PSA vary during the day or over the period of 3 months to a year? You know, PSA, as much as it's a perfect test, is a biomarker that we use and we don't have it in a lot of cancers, it really can be, it really can also be falsely high or falsely low. As I said, different reasons like inflammations or exercise can take it up. Different time of day, I'm not sure if it really makes a big difference, but if as a patient, you go do a PSA test in one lab and you do one in another lab, there could be a 10 to 20% difference in the level of the PSA you get. And also if you do it if you do it at 2 different times, you might see this a little bit of a difference, but the difference shouldn't be dramatic. The difference is not more than 10 to 20% in the level. Mike is saying, what if your Gleason score is 6 and the PSA is under 10? Do you need radiation or surgery right away, or you should do active surveillance? So if your Gleason score is 6 and your PSA is low, you fall into the low or very low risk. And active surveillance is always an option in those groups. My recommendation is to have a long conversation. These are the hardest patients, I can tell you. Long conversation with your radiation oncologist and your urologist to decide what's the best treatment. Now, the genetic tests that Dr. Schrader talked about, those, some of them like the Decipher test, help us identify which, or the Oncotype, help us identify which are the higher risk prostate cancer patients. So which are those patients that would benefit from more definitive treatment rather than active surveillance. Guy is asking, when might you recommend docetaxel for oligometastatic castration-resistant prostate cancer or low volume? So if these patients are just diagnosed with oligometastatic low volume castration-resistant prostate cancer, so basically, in other words, hormone-sensitive metastatic, I would not recommend docetaxel because there was a trial, the Charted trial, that looked at patients and gave patients with metastatic hormone-sensitive prostate cancer as the first line of treatment. They were given docetaxel, and they did not do well. They did even worse if they were hormone sensitive. Now in castration resistant, which is Guy's question, that's a different story. I personally prefer not to jump on docetaxel if there is only a couple spots of metastasis, but it depends on how old the patient is, what other comorbidities they have. If I'm going to, there are studies now ongoing on oligometastatic prostate cancer, castration resistant, that they radiate the primary, which is prostate, if it's still there, or they radiate the spots from cancer if they're on bone or areas that we can radiate. So in those cases, I would rather, if I'm giving a patient docetaxel in that setting, I would rather give them under a clinical trial, just to make sure that we are doing the right thing for the patient. Most of the times we prefer, in oligometastatic patients, most times we prefer to treat them with an androgen receptor pill. Ben is asking if is PSMA treatment only used with advanced metastasized cancer, or can it be used with local? So we don't have really much data in localized prostate cancer yet. As you saw in that slide that we showed timeline of FDA approval, usually when we are investigating drugs, we look at them at after many lines of treatment and we get them approved there, and then we start moving them forward. We are now investigating PSMA treatment in patients who are newly diagnosed. And I'm assuming in the next few years, PSMA will start getting investigated in non-metastatic patients or localized patients. I'm sure that will happen probably after a few years once we have more data on the first line setting. And Louis is asking what clinical trials are underway at UNM Cancer Center. So all those slides that I showed about clinical trials are the ones that we are trying to open at our cancer center. We also currently have other localized trial with radiation oncology. We have a trial in our prostate cancer patients whom are starting radiation plus androgen deprivation therapy. This is again a National Cancer Institute trial. And basically we want to make sure that these patients don't develop so many side effects. So we give a report of their treatment and what their primary care doctor has to look at from side effect standpoint. We communicate with the primary care doctor, so it's advanced survivorship in patients who are receiving definitive treatment for prostate cancer. And anonymous attendee is saying, how does the cancer cell mutate after a successful curative treatment? So I'm going to quote one of my mentors. Cancer is smarter than 10 doctors, or maybe 100 doctors. Cancer, no matter how we treat it, cancer always finds its way to develop a resistance to the treatment that they're receiving. So no matter what you do, at some point, the cancer cell will mutate. And unfortunately, now this is what we are looking into, to find reasons of mutations and resistance to specific treatments and try to prevent those, but we are still so much behind on a lot of those. Another anonymous is asking that I've had 2 meds, even though I'm on AD therapy with abiraterone and Trelstar. Is there a trial I'm eligible for in testing lutetium with PSMA? So the trial, the lutetium trial that's opening now, is for patients who haven't received any treatment yet. However, I think I'm really positive that FDA will approve this lutetium in the first quarter of 2022. So hopefully you'll be able to receive that. I'm sure there are other trials. I'm not aware of trials for oligometastatic after abiraterone to receive lutetium. We don't have one. I'm not aware of any in the other centers in New Mexico. But I think it will get approved. So you wouldn't need to go on trial for that. And then Woody is asking, when is it appropriate to stop ADT for a period of time? So in localized prostate cancer, there has been a lot of studies looking at continuous ADT versus intermittent ADT, meaning giving breaks. And we know that in patients with certain Gleason scores, such as Gleason score of less than 8, or certain PSA levels, it is safe to give intermittent ADT, and they would live as long as patients who get a continuous. In patients with metastatic, we know, or with patients with high Gleason score of 8 or 9 or 10, we don't know. In patients with higher Gleason score, we don't know if it's safe for them to do it. And in patients with metastatic, we know that continuing ADT is better. Now, that being said, there is very small number of patients that we see that are just those miracle patients that their disease completely, they have metastasis and it completely goes away with ADT. And in those patients, if they're having symptoms, even although they were metastatic, we can give them breaks while watching them very closely. And then another anonymous is asking, when the FDA approves PSMA lutetium, hopefully next quarter, how long will it take at UNM Cancer Center to offer this treatment? That's a very hard question for me to answer, because we have been working on this for the past few months to be prepared for the FDA approval, as well as to be able to open the trial for hormone sensitive patients. It needs a lot of infrastructure. We have a very strong nuclear medicine team. This treatment is given with the help of nuclear medicine team. We already have theranostics, which is similar in neuroendocrine tumors that we're giving at UNM Cancer Center. So we have the infrastructure, but we have to expand that. And we have to be able to get the generators for producing the PSMA galliums for the PET CT. So there's a lot of stuff that goes on. The UNM Cancer Center director is very, very supportive of this treatment and the trial. Dr. Dayo also is very supportive. She's our current chair. So I'm very hopeful that once this is approved, we will be able to offer it to our patients. I think that's all the Q&A that I have. I don't know, Steve, if there is anything else that we missed.
Doctor, we just got one in by chat instead of by the Q&A. I'll just go ahead and read it to you.
Okay.
This gentleman's PSA has begun to rise 4 years after a prostatectomy. At what level PSA can or should PET scan be useful, and at what level PSA should treatment be started?
So again, the level of PSA doesn't matter as much as the doubling time of the PSA matters. So if your PSA doubling time is 10 months or less, I think we should do a scan. And the best scan to do, if your insurance would approve it, would be one of these molecular scans, such as the fluciclovine scan or the oxamine scan that we have at X-Ray Associates. Those are the most sensitive scans to identify recurrence or metastasis. And if that scan doesn't show anything, then I would feel more comfortable just watching the PSA, because if you look at the NCCN guidelines, observation is also an option in such cases. And I think there's something else also. Any immunotherapy at BCR to nip the prostate cancer in the bud instead of waiting for it to grow stronger. And okay, and metastasize. How about clinical trials? So unfortunately, immunotherapy drugs alone, such as Keytruda, have not shown much benefit in all comers prostate cancer, meaning they're only showed benefit in prostate cancers with microsatellite instability high. But a lot of combinations are being investigated. And I'm assuming that soon immunotherapy combinations will also get approved in prostate cancer.
Okay.
I think that's all.
Thank you so much,
Yeah,
Doctor.
thanks.
You've been very informative, and we really appreciate taking some time out of your day to talk to us. Okay. You have control of my screen because you're already sharing your slides. So I'm just going to go ahead and read this brief introduction to you and let you take it away, if that's okay. Just for those people that are not familiar with Dr. Scolz, he is a strong advocate for back up here. He's a board certified medical oncologist, serves as medical director of Prostate Oncology Specialists, Inc. In Marina del Rey, California, where he is coming to us from California today, and we really appreciate your being with us, Doctor.
Thanks for having me.
Also the executive director of the Prostate Cancer Research Institute, which we heartily endorse. And he received his medical degree from Creighton University in Omaha. Dr. Scolz completed his internal medicine internship and medical oncology fellowship at University of Southern California Medical Center. And Dr. Scolz is a strong advocate for patient empowerment. He is a co-author of several books, one, Invasion of the Prostate Snatchers, No More Unnecessary Biopsies, Radical Treatment or Loss of Potency, and has written and produced extensive educational material on the subject of prostate cancer. He is frequently an invited guest speaker in the community at prostate cancer conferences and prostate cancer support groups. He is also an educational speaker on behalf of Amgen, Dendrian, and Sanofi Aventis. Doctor, we just appreciate you so much, and we're looking forward to what you have to say.
Well, it's a pleasure to have an opportunity to talk about this exciting topic today. Thanks for inviting me, and thanks for putting on this, this meeting to help out patients. It's really wonderful. All right, well, I think we're supposed to jump right in then with that. And the topic today, which I was assigned by the leaders of your meeting, immune therapy for prostate cancer. Immune therapy is an absolutely vast topic, very challenging to try and condense into 45 minutes. And we're going to focus on the types of immune aspects of immune therapies that are focused for prostate cancer. And even that, we'll have to go over this very, very quickly. What we call cancer is a condition of uncontrolled cell growth. It's very complicated because there are many different mutations in the normal cell that have to occur for it to become a cancerous cell. And this slide lists some of the necessary changes for cells to become immortal, for them to start spreading and metastasizing, for them to be able to land in a foreign part of the body and grow as a metastasis. So the point we're going to be focusing on is that these cells also have different mechanisms for avoiding our own immune systems from eradicating them. Your body relies on your immune system to keep early cancers under control. And so some of the cancer cells develop the ability to evade the immune system. What we call the immune system is difficult to characterize, but most people are familiar. They've heard of lymph nodes, which are sometimes removed at the time of surgery. There's also the spleen, there's the bone marrow, and what we call the immune system is essentially very specialized cells, white cells, that circulate in the blood, in the lymph, and then have certain characteristics that we're going to go into a little bit that describe how these cells go after cancer cells. One of the things we're going to focus on in this talk are a specific subtype of white cell called the antigen-presenting cells, or the APCs. These are the cells that start the whole cascade going for trying to fight cancer. The T cells, which we're also going to talk about, are the so-called soldier cells of the immune system. But when we talk about the immune system, it's not just cells. We're surrounded by bacteria and viruses, and these agents can, if they get through the skin, can become very dangerous. So our skin, our mucous membranes, all these things are designed to protect us just as the immune system. And then if they get past those barriers, then we're relying on the cellular components of the immune system to detect and then attack and eradicate them. This picture here shows some T cells attacking a cancer cell. And there's actual interactions between these cells. The T cells approach and get next to these cells and inject things into them and create a methodology where the cells will actually die. And there have been a number of different medicines that have been designed to stimulate this process, enhance it, and encourage it to be more effective and efficient. And that's part of what we're going to go into today. So there's been, we've known about the immune system for, ever since vaccines were developed, but the idea that the immune system even exists, of course, is a relatively new idea of maybe 100 years or so that it's been around. And there have been doubts and naysayers saying that, we can't really affect the immune system and it's not contributing that much. And I think part of the reason is that the immune system operates so efficiently and so silently. We all in our intestines have, a lot of bacteria that are kept in check by your immune system on a constant basis. And it does this very efficiently and very quietly. So one thing that shows how the immune system is protecting us from cancers can be seen in people that go through immunosuppressive therapy when they undergo organ transplantation. So if a person gets a kidney transplant or a heart transplant, those organs from a different person are detected as foreign foreign organs, and they have antigens that are not present in the original person. These antigens can be detected by the immune cells of the new host, and then the immune system can start to attack it. And so that the organ does not get rejected by the immune system, immunosuppressive drugs are given to inhibit the activity of the immune system. So you can imagine then, if the immune system is being inhibited, that it would also inhibit other aspects of the immune system, and these could lead to people getting cancers more frequently. So that's the hypothesis, and a number of studies have been done in people that have had transplants, demonstrating clearly that the incidence of other types of cancers showing up in immunosuppressed people from organ transplants, that these different cancers occur with a great increased frequency. If you scroll down on the list here, you can see that the incidence of prostate cancer doubles in people that have had organ transplants. It's 15-fold higher for kidney cancer, is 15-fold higher in people that have had organ transplants, and so on. So this is simply to validate how important this very silent and efficient system working in the background is in keeping cancers away. Other evidence that shows that the immune system is really working on our behalf to protect us from cancers have been demonstrated in studies where they look at biopsies of cancer tumors and count how many immune cells are infiltrating into the tumor itself. They've shown that people that have higher T cell counts infiltrating the tumor live longer than people who have lower counts. So there's a direct correlation to how well the immune cells, the T cells from the immune system, penetrate the tumor and how long people live. So there is this ongoing balancing act between the, let me go back here. Between the cancer cells trying to get away from the immune system or hide, and the immune system itself being stimulated and enhanced and strengthened to fight the cancer. And the immune system then accomplishes the eradication or the suppression of the cancer with varying success. And this dynamic process can be summarized as the three potential outcomes from the immune system are the actual elimination of the cancer cells, an equilibrium stage where the immune system inhibits further cancer progression, doesn't eradicate the cancer, but stops or slows its growth. And then an escape phenomena where the cancer just is too much and the immune system is unable to control it. So as we talk about the different ways that this works, we're looking at how in different scenarios the immune system can accomplish either suppression of the cancer growth or even eradication of the cancer cells. So this is an example of eliminating the cancer. The T cells approximate with the cancer cells and then kill them off. And then once they die, then let's see, let me go back here. Once they die, the normal tissues grow back and the cancer is completely eliminated. The cancer in this diagram is illustrated by the brown cells. So normal cellular structure is restored. An equilibrium stage is accomplished when the immune cells are approximated to the cancer and the cancer does not disappear, but neither does it progress or grow into a larger tumor. And then if we have a further example of when the immune system is not able to control the cancer, we see that despite the immune system engaging with the cancer cells, unfortunately, the tumor keeps growing. So let's go into some definitions. This is our most technical slide in the talk today. And as we go through and look at these different components of the immune system, we'll also be able to get a sense how some of the common medicines that are used to treat prostate cancer are functioning to enhance the immune system. The T cells we've already mentioned. These are the soldier cells or the activated lymphocytes that seek out and approximate with the cancer cells and then attack the cells and kill them. or suppress them. The antigen presenting cells, or the APCs, these are the cells that detect abnormal antigens and then subsequently activate the T cells. And the antigens, these are the molecules that are not present in our body, but can be detected as strangers. And these protein molecules are what are detected so that the immune system swings into action. Antibodies are specialized proteins that stick to these antigens. And they have two components, a sticky side that sticks to the antigen and a protein side that sort of waves like a flag so that the immune system can detect them and realize that they're sticking to an antigen, a foreign antigen, and that this cell needs to be attacked. Cytokines are special hormones that are secreted by immune cells that stimulate the overall immune response. So as you can see in green, we've listed some medicines, which we're going to circle back to as we go through this talk, that are used in the treatment of prostate cancer, either on or off label. Keytruda, Provenge, Leukine, and then a process we call antigen spreader, the abscopal effect, which we'll go into in more detail. I threw in, I know the next talk is going to be about the PSMA PET scans and lutetium-177, and this is such a big breakthrough that it deserves a talk of its own. But it's interesting to note that this whole technology is built on the fact that you can synthesize antibodies that will stick to foreign proteins or even natural proteins on the surface of cancer cells. The protein that we're specifically talking about is PSMA. And so an antibody that sticks to PSMA, which occurs on prostate cancer cells, is able to then flag down the immune system, or it can also drag a radioactive molecule that can be either scanned, or if it's a powerful radioactive molecule, that can actually radiate the cancer. So it's not really an immune therapy like the other four green things that are listed on this page, Keytruda, Provenge, and the antigen spread and Leukine, but it is a giant breakthrough, and you're going to have an extensive talk on the subject following mine. So let's go on to the immune system here. So in this cartoon, we're going to illustrate the process. The little round balls are the foreign antigens. The large round APC, that's the antigen presenting cell. And once it recognizes a foreign antigen, it activates, as is illustrated, and starts to grow and change. And then it seeks out T cells, which it then activates. So it's a two-step process where the antigen presenting cell is transformed into an active form and then starts activating the T cells, which can then replicate and grow and go on to attack cancer cells. And so it's the activation of the antigen presenting cell that starts the whole cascade process. And this has been demonstrated. This is a scanning electron micrograph showing T cells attacking the purple cancer cell, and the dynamic process of how these cells approximate and eliminate the cancer cells. So this whole vaccine and immune world, as I mentioned before, has only been around for about 100 years. Some of the early things that were attempted were actually rather ridiculous and quite ineffective. But about 30, 40 years ago, they did discover that a vaccine that was used against tuberculosis called BCG also had a non-specific stimulatory effect on the immune system. And this is actually used to this day to treat low-grade bladder cancers. This is instilled into the bladder itself, and along the bladder wall where the bladder cancer is, this BCG stimulates an immune reaction and keeps the bladder cancer in control. This process has been very slow, and it's been with fits and starts, but there were some cytokines or hormones approved, one of which is we're talking about today, called Leukine. And the Leukine was originally approved is granulocyte macrophage colony stimulating factor, the GM-CSF, or leukine is the trade name. It's an injection that was originally approved to boost the white blood cell counts in people getting chemotherapy. And it's very effective for that. And chemotherapy historically has been given to a dosage that pushes the immune system temporarily right to the brink. And one of the risks of chemotherapy has been infections because of the transient suppression of the immune system. When leukine and a competitor to this called Neupogen were FDA approved, this really changed the ease with which we can give chemotherapy. It was very useful for that purpose. But some people have taken this same medicine, GM-CSF or leukine, and since it stimulates the immune system, they hypothesized maybe it can also stimulate the immune system to attack cancer cells directly. And while leukine has never been FDA approved to treat prostate cancer, it has been looked at in several studies. Eric Small up at UCSF did a study in, I think, 40 or 50 patients who had rising PSAs after surgery. And this is kind of an attractive space because back when they were doing these studies, this is all 15, 20 years ago, the only other alternative was Lupron. And Lupron blocks all the testosterone out and therefore is unattractive for that reason, even though it's very effective. So he found in injecting leukine, subcutaneous injection like an insulin shot in the skin every 2 weeks, and then 2 weeks off and 2 weeks on and 2 weeks off, that about 20% of the men that had rising PSAs after surgery maintained stable low PSA levels for up to 5 years. And they didn't test beyond 5 years. But I've also had patients who've been on this medication for extended periods of time with stable PSAs. It seems to be an effective medicine when there's a relatively small amount of cancer. And this is sort of a recurrent theme in the immune world, which we'll circle back to. But it is generally well tolerated, although stimulation of the immune system sometimes can cause some joint aches and body aches, sort of like if you have a virus or something like that. For the most part, people don't complain much about the side effects associated with leukine. And it clearly has activity, but it's never been FDA approved. So the biggest problem with leukine now in 2021 is, first, it's only going to be for people with relatively small amounts of cancer, and you're not going to use it in the newly diagnosed because we've got a lot of other better options. But for someone that's trying to sidestep the use of Lupron in the relapse setting, it could be an attractive option. So the more recent developments are very exciting because there's a whole mechanism, and we'll illustrate this more fully in a moment, but to keep your immune system in check. Immune systems that are running out of control, rheumatoid arthritis, lupus, multiple sclerosis, can really wreak havoc. And so when the body creates an immune reaction, it also creates different methods to slow the immune reaction down so it doesn't burn out of control like a fire, but accomplishes what it needs and then regresses back to its quiescent state. So big breakthrough when they discovered that that there are ways that we can slow down this checkpoint process or these braking systems. So if you think about it, if you take the brakes off the immune system, that the overall immune activity is going to be enhanced. And if we're fighting cancer, the risks of an overactive immune system may be less dangerous than the cancer itself and certainly justified. So Yervoy was the first checkpoint inhibitor approved about 10 years ago. And then a cellular immunotherapy, which we'll go into a little more detail, was also approved in 2010. So these are the four types of immune treatment that I think of when treating prostate cancer patients. We mentioned Yervoy and Provenge already. Keytruda is a medicine similar to Yervoy that also blocks checkpoints that regulate and reduce T cell activation. Leukine we've talked about. And then another phenomena called antigen spread sometimes is elicited in men with metastatic prostate cancer by giving spot radiation to tumors. Antigen spread we'll go into in more detail as well, but this idea that you can that when you kill off a few cancer cells, that you are able then subsequently to create more antigens that the immune system can detect, has been shown in some cases to cause regression of tumors in other parts of the body that aren't even radiated. So this is how the checkpoint inhibitors work in a diagram format. You see the activated APC cell at the top of the image there, activating the T cells, which are then going after the tumor cell on the far right. And then the interaction between the surfaces of the T cell and the APC is magnified. And you can see where Yervoy, which is signified by the little yellow Y-shaped things that are blocking the CTLA-4 antigen. CTLA-4 is, if it's activated, if those little red baseball bats stick into the CTLA-4 active site there, then that's going to slow down the process of T cell activation. So what Yervoy does is it just gets in the way of that slowing down process. And that is in the step between APC cells and T cells. Keytruda has a similar mechanism of action, except that it's blocking a different receptor that is on the surface of T cells, and it blocks out it blocks out the tumor cells from being able to connect with the PD-1 receptor. And if they do connect with the PD-1 receptor, then that's going to tell the T cell to go away. So if you keep that process blocked, then the T cells will continue to do their business, attack and kill the tumor cells. So Keytruda and Yervoy have been approved for multiple different cancer types. Keytruda is in phase 3 trials for prostate cancer. We've treated over 100 patients on a compassionate use basis, and it has activity, again, mostly in the androgen-independent patients or androgen-sensitive patients with relatively small amounts of prostate cancer. Yervoy, on the other hand, was tested in 2 huge phase 3 trials that were headed up by one of our favorite speakers at the PCRI, Dr. Eugene Kwan. And in the first trial, Yervoy was studied in very advanced prostate cancer, and it was studied in combination with spot radiation to a metastatic site to induce an abscopal effect. So it was actually a combination treatment of Yervoy and spot radiation. And that clinical trial, which was published in the New England Journal of Medicine, if I recall correctly, came this close, literally a half a percentage point away from FDA approval. It was, if they'd had just 1 or 2 more patient responses, it would be a standard treatment that we'd be using to this day in prostate cancer. But because of the way the laws are set up, that particular trial did not qualify. So Bristol Myers, who makes Yervoy, decided that this is certainly an active agent and it should be repeated in earlier stage patients, because the general belief is that immune therapies are going to work better against less advanced cancers. And such a trial was initiated, but unfortunately, they failed to incorporate the spot radiation component of the first trial. And it also did not reach statistical significance. So Yervoy is not FDA approved for prostate cancer, but it came so close to getting approved. And there's certainly demonstrable activity for this agent. Unfortunately, without FDA approval, it's expensive and difficult to access as the insurance companies are unwilling to pay for it. Keytruda, on the other hand, is still in the development process, and the phase 3 trials have yet to be completed. As I mentioned before, we've had experience with this medicine in prostate cancer patients, and it seems that about half of the patients that we administer this medicine to have a meaningful either slowing in the rate of their PSA rise or sometimes regression of their PSA. There's a doctor at UCLA, Dr. Joanne Wheathouse, who has developed an assay to detect which patients are genetically susceptible to, to side effects from Keytruda. And she can predict in advance, based on a mouse swab or a blood test, whether a patient who gets Keytruda is likely to have side effects. So with that use, this medicine, which is infused every 3 weeks, can be given really quite safely. When patients do have side effects from Keytruda or Yervoy, they can be rather dramatic and serious. The immune system, when it's out of control, can be a very, very daunting prospect. So now moving on to how Provenge works. So the idea of Provenge is that the activated APC cells, again, stimulate the T cells, which then go and attack the cancer. So how do these APC cells get activated? Well, what happens is in the process of Provenge treatment, men go through a, it's like a dialysis process, leukapheresis, where APC, non-activated APC cells are taken out of the bloodstream and then transported to a facility either in, I believe in Atlanta and Seal Beach, California, where they are processed with leucine and put in a vat with leucine and with a specific antigen that's very common in prostate cancer called prostatic acid phosphatase. So this mixture is then swirled around, and the APC cells detect PAP as a foreign antigen, and they become activated, and then they are replicated partly because of the leucine that they're receiving. And then this new slurry of cells is reinfused into the same patient. So the patient that gets the infusion, he's getting infused with cells that came from his own body. This process is repeated cyclically for every 2 weeks for a total of 3 treatments, and then the treatment is finished. So Provenge has been demonstrated to prolong life in people even with very advanced cancers, advanced prostate cancer, but the degree of prolongation in people that have PSAs in the hundreds or something like that is not that long, a few months, at least on average. Some people certainly longer, others don't even get any benefit. But the impact can be much more substantial if people are treated at an earlier stage. And this is where Provenge fits, is in people who have been on Lupron for some period of time because of a cancer relapse, and then their PSA starts rising. These are the individuals that need to go and get one of these new PSMA PET scans, find the spot, consider radiating the spot, of course, and then at that juncture also be administered Provenge. This is when Provenge is likely to work best. And since it has very few, if any, side effects, it's a very natural thing to use at that stage. So I want to just elaborate a little bit more this abscopal effect. It can be from radiation. Actually, it can be from any type of cancer treatment that kills cancer cells, not from surgery. Surgery removes the antigens, but anything that kills the cancer cells in sight, cryotherapy, HIFU, radiation, will create new antigens that your immune system can detect and then create a stronger immune response. So when the radiation, is illustrated on the far left, is administered to the prostate area or to a tumor, say, or a lymph node in the pelvis, is being demonstrated in this picture, that kills cancer cells. And those cancer cells then will release the new antigens, which then can be detected by the APC cell. And then the APC cell can activate new T cells that are going after different antigens than the original antigens that they may or may not have detected. And this is called the process of antigen spreading. And this is the idea that has been observed in patients that have undergone spot radiation, say to a single site, a bone metastasis or a lymph node, and on subsequent scanning, without any other cancer therapy, have demonstrated regression in tumors in other parts of the body. So just killing one tumor with radiation then creates an immune reaction that can allow the immune system to go on and kill cancer in other parts of the body. It doesn't certainly happen in every patient, but when it happens, it's an effective and real effect, and it may be better if these things are used in combination. And this is what we saw in the clinical trial where Yervoy came that close to FDA approval, is that they used both the spot radiation plus the Yervoy, and they came very, very close to getting statistical significance in their large phase 3 trial. So this rather complex graph illustrates the idea of what immune system may be accomplishing. And this illustration, I think, is important because historically, when we talk about treating something with hormone therapy or chemotherapy, we show efficacy by seeing a sharp, perhaps a 50% decline in PSA. And that is not a common reaction to immune therapy. In immune therapy, it seems that, especially in patients that have more advanced cancers, that it's more likely that what's happening is that it's slowing the cancer's progression rather than causing a sharp regression or disappearance of cancer cells. But that's not to say that's disadvantageous, because patients with these growing tumors are on a road to cancer mortality at some point. And this is illustrated in this graph here. If you look at the far left, you can see the lines sharply angled upwards. And then if a patient were to receive no treatment whatsoever, he would be projected to die at some specific time point in the future. But if administered an effective immune therapy, you could see how if the rate of growth can be slowed, that this will extend survival. And that possibly with combination immune therapies, you could get regression or further slowing and even longer survival. So the idea that PSA must decline to demonstrate efficacy is a specious argument when we're talking about immune therapy. And it's kind of sad when sometimes even sophisticated physicians or naysayers, I don't know how they can look past the fact that double-blind, placebo-controlled clinical trials have been done with Provenge, for example, showing better survival in the treated patients compared to the ones that received placebo alone. So you can also see, using the same idea, that if cancer treatment is initiated when there's less cancer to control, that you're going to get a greater impact in survival prolongation. And so this is illustrated by patient A, who without treatment, you can see the dotted line extending up to his projected time of death, but who with treatment at an earlier stage is going to change the rate of growth at an earlier stage and thus improve survival, compared to a patient who gets treated at a later stage and who will not have as big an improvement in survival. So in summary, some of the concepts that we wanted to transmit to you today are that there's no doubt that the immune system is going to be the wave of the future. We already have effective, useful, tolerable medicines, and they do need to be used selectively in certain subtypes of prostate cancer. It's not for everybody. It's not for early stage prostate cancer. Early stage patients, we have other feasible options. Immune therapies, if they cause side effects, the side effects like the immune benefits can be very long lasting. So there's a risk benefit ratio that is always being weighed when someone is put on an immune therapy. But there's no doubt that the immunotherapies do boost the immune system, and that by boosting the immune system, you can prolong survival. This has been demonstrated with several different approaches, as we have gone over. Just to reiterate, the rates of change of PSA are not going to be the same when you're evaluating how effective an immune treatment is. And the idea of using treatment in combination or earlier in the course of patients' treatment for prostate cancer is likely to accrue bigger benefits than waiting to the last minute. So thank you very much. Here's just a quick image of the books that we have out. The one on the left is a book about the prostate cancer culture in general. The one on the right is sort of a how-to manual on how to manage the 5 different stages of prostate cancer. And thank you so much for having me.
Well, thank you, Doctor. So, Doctor, the question is, this gentleman's metastatic prostate cancer, he's got a Gleason 9, was treated with radiation in 2018. PSA is currently undetectable. He's wondering if he should go for Provenge soon, or should he wait for a rising PSA? And at what level would that PSA indicate going for Provenge?
Sure. So yeah, if he has metastatic disease, his insurance will pay for Provenge, which is an expensive treatment, as soon as the PSA is demonstrated to be rising. So the PSA can go from 0.2 or 0.02 to 0.06 to 0.10, which would be a sequence of 3 rising PSAs in a row. And he would be eligible for Provenge. And that's exactly when I would do it. I would do it sooner if we could find a way to talk the insurance companies into paying for it, but generally speaking, they won't. I know Medicare won't. So but the idea of giving the Provenge as early as possible, I suppose if he's a billionaire, he could go buy some Provenge right now. But most people don't have that resource, and I would do it at the very first sign of a rise in PSA.
Okay, thank you. Let's see if we've got any more questions here right away. You did such a good job of covering things here. It's
Thank you. Yeah, it's it's complicated, but I thought it was useful for people to get a sense of how and these are very simplified presentations of what's actually going on. It's rather miraculous what our immune systems are accomplishing. And this gives us great hope since we're able to achieve tumor responses with our limited understanding of the immune system. Imagine how much improvement there is going to be in the future as a deeper understanding of the immune system becomes more apparent.
okay. We have a couple of questions here. First one is, are there synergies with starting immunotherapy in the months following SBRT for metastatic cancers?
We think so, because of the information we presented today, that we will commonly, if a patient is getting Provenge, think about giving stereotactic body radiation, which is a very short course of high intense radiation, to a spot of cancer in the patient's body during or immediately after the Provenge. We think that the idea of giving them concomitantly is potentially advantageous.
Okay, thank you. And then another gentleman said, did I understand correctly that an immunotherapy approach is for later stage prostate cancer only rather than earlier stages?
Yeah, it depends on where we draw the line between early and late. But the patients who are candidates for immunotherapy as of 2021 generally have some sort of metastatic disease. Ideally, very little. That would be probably the optimal type of patient for these medicines, is someone that it has been demonstrated that the cancer can spread. Many patients with early stage prostate cancer have variants that don't spread, thankfully. And that's always the important question in any cancer is, does this individual have a type of cancer that can spread? Or is this an individual that has one of these common cancers that won't spread? Now, you can't just look at the Gleason score and know the answer to that. Really, time will tell. And but the patients that have even one lymph node that is spread, that's usually the earliest sign, is maybe cancer showing up in a lymph node in the pelvis. That bespeaks of a cancer that has a genetic capacity to get outside the prostate, to land in a foreign part of the body and prosper and grow. And that's what we worry about. Cancers that stay home in the prostate are relatively harmless. The prostate tolerates these tumors quite well. It's not really that big a deal. It's just the fear of potential spread. So the immune therapies, Provenge doesn't have a lot of side effects, and it has been studied. There's a recent clinical trial looking at men who are on active surveillance. That's the earliest stage of prostate cancer, and perhaps the most harmless type of prostate cancer. And I'll be interested to see what that study shows. I don't know what the outcome of that study was, but since Provenge is very well tolerated, men generally may have a few fever and chills on the day of the infusion at most. It's pretty much devoid of side effects. It'd be a very natural thing to use even earlier. But because it's expensive in that it's not covered by insurance for those stages, it's the men that have early metastatic disease that are in line to get it first.
So would you say that metastatic disease is a starting place, or there's no chance that it would happen while it was still in the capsule, so to speak? Is that right?
Well, it's we'll see what the clinical trial shows. And we'll see if the FDA believes that if it works. So what they did in that clinical trial, men that were on active surveillance who had some risk factors were half of them got Provenge, or 2/3 of them got Provenge, 1/3 of them did not. And then this large group of people then were monitored and rebiopsied after 18 and I believe 36 months after starting the active surveillance process. And patients that developed larger amounts of higher grade cancer were taken off active surveillance. So the big question is, did the men who got Provenge have a lower incidence of coming off active surveillance compared to the men that didn't get Provenge? And if that shows a lower progression rate, that would certainly validate the efficacy of Provenge in that setting. Doesn't make the medicine any less expensive. And unless the FDA buys into the idea that this is something to help men with early stage, then getting it covered will be a challenge. But I eagerly await the results of that trial. I believe that it's going to be released very soon, actually.
All right.
Yeah, Mike Moore is the next one.
Hold on a second. Okay.
We've got a whole bunch more.
We just got a bunch in here, so we're just kind of sorting through these.
Mike Moore.
I'm sorry, Mike.
Mike Moore.
Okay. This kind of is related to my last question. If your Gleason score is only 6 with a PSA of 8.5, but a biopsy shows high volume, should he be acting now with radiation or surgery, or wait and see if the PSA doubles?
So that's an active surveillance question, not an immune question, but I'm happy to field it. It's a very important question. So as we said before, the thing we are concerned about with anything called prostate cancer is the likelihood of spreading outside the gland. In men that have high volume grade 6, they're not more likely to have disease spread outside the gland as long as you're sure that it's really all grade 6. People that have higher grade or larger tumors, there's probably a statistically higher chance that there's something higher grade lurking there that maybe wasn't detected on the biopsy. So we do indeed watch patients with grade 6 that have larger tumors in the prostate because grade 6 doesn't spread. But we are more vigilant because we realize that, especially with random biopsies, that there's a possibility of missing higher grade tumor that wasn't seen on the biopsy. So we scan these people frequently or annually with the MRIs and color Doppler ultrasounds. And as long as the quote large tumor doesn't grow bigger or change in its character, we keep watching. If it does change, then we do another biopsy to see if we've missed some higher grade component that does need treatment.
Okay. I think we have covered our question. Oh, we have another one here. Dave?
There's several more down. Can you pull yours down on your?
I'm doing that. I apologize here, doctor. I'm just okay. There's one at the bottom here. It says post prostatectomy, what rising level PSA constitutes BCR, and any clinical trials underway on immunotherapy at point of BCR?
So the historical threshold used in academia is 0.2. But this is a bit arbitrary because some men who undergo radical prostatectomy, their surgeon doesn't get the whole gland out. And these men can have lingering PSAs that are above 0.2 that don't come from cancer. So it has to be interpreted in light of the doubling time. If the PSA is 0.3, but it never goes up, that's not cancer. It's a piece of prostate that was left behind. But that's the working definition, is 0.2. And these patients, I'm not aware of any clinical trials ongoing right now, although as I mentioned in the talk, we did have Dr. Small did a clinical trial giving these men a cytokine or an immune stimulating medicine called leucine, and was able to stabilize the rising PSAs long-term in about 20% of the patients. So there is certainly a possible role for leucine in men that are trying to avoid getting Lupron. Now, with the advent of PSMA PET scans, many times we're able to look closely and find where the cancer is, radiate the recurrent cancer, and cure it. So the idea of simply suppressing the PSA either with Lupron or leucine may be kind of an outdated thought with the advent of these new PSMA PET scans. Perhaps if someone's tried that and it didn't work, which can happen, then the leukine or lupron is going to come into play. But many of these people that have rising PSAs after surgery or radiation should definitely get a PSMA PET scan. And if they can find the recurrent spot, radiate it, possibly even cure it.
Okay, thank you very much. I think that takes care of our questions. Since we're long distance, we don't have a T-shirt for you. I know that that's a tradition with PCRI is developing T-shirts, but we'll figure out something to show our appreciation to you, Doctor.
Well, thank you for inviting me. It was a pleasure. Great topic, difficult topic, but I think it was important that we cover it.
Well, and you did an incredible job. We just thank you so much. Our next presenter is Dr. Gregg Franklin, and he is a board-certified radiation oncologist. Okay, I'll make sure that my screen is showing correctly here. Currently serves as the medical director of radiation oncology at the New Mexico Cancer Center. Prior to working at the New Mexico Cancer Center since 2005, he completed his residency at Washington University Barnes Jewish Hospital in St. Louis, Missouri. Prior to his MD degree, Dr. Franklin earned a PhD in condensed matter physics at the University of Illinois at Urbana-Champaign. Between these degrees from 1992 through 1996, he was a postdoctoral fellow at Harvard University. These credits are incredible here, and a scientist with Sandia National Laboratory in Albuquerque. I'm hoping that Sandia was the reason that they brought you here. Okay. He is currently a fellow with the American Society for Radiation Oncology, American College of Radiology, and with the American Society for Clinical Oncology, College of Radiation Oncology. Dr. Franklin, we're so glad you're with us.
Okay, great. So as I mentioned, I'm one of our radiation oncologists, Mexico Cancer Center. You can see that in the image below. Our main center is at the Journal Center. I've been there for over 15 years. We have a number of treatment modalities on radiation, chemotherapy. We have urologists, radiologists, pulmonologists, et cetera. We will be getting proton therapy also in the next couple of years. But I personally have a particular interest in radiopharmaceuticals, and today I'll be talking about latest developments in imaging and treatment of advanced prostate cancers. And Steve, please feel free if there are questions to interrupt me during my presentation. I have a very limited amount of time, and even less so now that I've had trouble getting the images going. But I did make my slides, some of them a little busier, and I did that just because if you wanted to share my presentation in the future, there are some resources on some of the slides if people want to get more references or a little greater detail. So I'm going to be kind of going through the presentation pretty quickly because I was asked to cover both imaging and treatment, and there's a lot of material there. So let's get started. First, we're going to talk about radiopharmaceuticals. I'll briefly talk about what they are, some general properties. Then we'll move to talking about radiopharmaceuticals in both imaging and treatment for metastatic prostate cancer. I'll review some of the most recent data. I've kind of defined things as my own definition of sort of first generation scans or first generation molecules and second generation scans and second generation molecules. And in between some of those, we'll talk about PSMA as previous presenters and everybody and a number of our I think participants know that that's kind of the latest hot topic, both on imaging and on the treatment side. So what are radiopharmaceuticals? So radiopharmaceuticals are radioactive medicines. They're radioisotopes used to both diagnose and treat cancer. They can be delivered orally, intravenously, inserted into cavities of the body. They can travel to different parts of the body. They can bind to specific cell receptors or areas nearby cancer cells. And the main components, as we'll see, are both a radioactive element that gives off various forms of radiation that damages the DNA cells, hopefully killing cancer cells with a minimal amount of side effects. And then there is the other aspect of the radiopharmaceutical, which is the ligand that allows for specific binding to receptors located on the outside the cancer cells. So to create a radioactive element, this is typically done with a cyclotron or a generator, and a stable element is bombarded by particles, creating an unstable or radioactive element. This radioactive element then decays with a certain half-life, and it decays by giving off various forms of particles. So as you can see in this picture, this particular decay can decay to an alpha particle, which is really a 2 protons and 2 neutrons, or an ionized helium atom. A beta particle, which can be an electron or a positron, can decay via X-rays or gamma rays, or a neutron particle that we won't talk about. Alpha particles have a very short stopping distance, meaning a piece of paper can stop an alpha particle. They only travel a few microns within the tissue, about 10 cell diameters, and they give up all of their energy. Beta particles travel a little further, a few millimeters into tissue. X-rays and gamma rays can travel through the body and then through steel or even concrete. So the first just example of radiopharmaceutical we'll talk about is from radium-223, that you may know as Zofigo or Zofigo. And this particular radioactive element decays mainly by alpha particles. So again, it's like a big bowling ball. Though that bowling ball gives up its energy over a short distance of 4,200 microns and causes what's called double-stranded DNA breaks, which is the most lethal form of damage. It's more difficult to repair that kind of damage than single-stranded DNA breaks. Beta particles, these are like electrons. These are like a marble in comparison to the alpha particle. These cause mainly single-stranded DNA breaks. It's more repairable. It travels over a distance of, on average, of a few millimeters. And then, as you can see from gamma rays, these travel much, much further in the tissue, and through your tissue, actually, causing single and double-stranded DNA breaks along the way. Now let's switch to another aspect of radiopharmaceuticals, which is sort of how that radioactive elements get deposited near or on cancer cells. So below is a general model of a radiopharmaceutical. The radioactive element is typically the drug that you'll see here, but of course it can be things other than radioactive elements. But in the purposes of this talk, this is a radioactive element. The drug, or it's attached to a ligand, and that ligand is a targeting ligand that targets certain receptors. So for instance, in the case of PSMA, you have PSMA 617. That's a ligand for a new lutetium treatment that targets the PSMA receptor on the prostate cancer cell. The ligand typically binds to the cell receptors. We'll see some cartoons of that coming up. It gets internalized within the cell and then delivers the lethal radiation both inside the cell, and the particles travel outside of the cell, killing other nearby cancers. Below are some examples of therapeutic radiopharmaceuticals. Some of the cancer types that radiopharmaceuticals treat are thyroid cancers, lymphomas, neuroendocrine cancers, bone metastasis from not just prostate, but other kinds of cancers as well, and of course the prostate. Isotopes are listed here for these various different kinds of treatments. And to the right, you can see the main decay particles that we've briefly touched on are predominant in these different with these different isotopes and in the decay of those isotopes. One example is a lymphoma cell. Again, here, this is an yttrium-90 radioactive element. It mainly gives off gamma and beta rays. It's attached to an antibody. That antibody binds to the CD20 receptor on a lymphoma cell. It gives off its damaging rays, killing that cell and nearby cells. Of course, the other nearby lymphoma cells, they also get bound by this yttrium-90, and so you have this kind of crossfire effect where you get a lot of cell killing in that area. So now we'll switch to talking about radiopharmaceuticals and prostate cancer. And mainly, firstly, we'll talk about how to image and detect them, how to use them to image and detect prostate cancers. Some of the useful imaging and testing terminology that I'm just going to mention kind of real briefly is that you may see, and that we'll talk about in this talk as well, is the sensitivity and specificity of a test. And we won't go into the mathematics of it, but basically the sensitivity of a test is the ability of a test to correctly identify those patients with the disease. In other words, true positive rates based on a gold standard, let's say like a biopsy or a radical prostatectomy. So a test with a high sensitivity identifies those patients that truly have the disease, whereas specificity is the ability of the test to correctly identify those who do not have the disease, what's called a true negative rate. So a test with a high specificity identifies those who do not have a disease. But probably what's most important from the patient's perspective are what's called positive and negative predictive values of a test. So as an example, let's say you get a positive test result. So if you knew the positive predictive value of that test and it happened to be high, you should be worried because that test has a high positive predictive value for your disease. However, if you get a negative test result and the test has a high negative predictive value, then you should be reassured that you don't have the disease. So, and then of course there's the converse. If you get a positive result, but let's say the positive predictive value of the test is low, then that positive value may not be real. So that's kind of the bottom line for these tests. They're not all 100% yes or no if you get a positive or negative value. So very briefly, in terms of bone scan, I'm not going to talk much about it. It's the radioactive element is technetium-99. This is the ligand MDP in terms of binding to the bony matrix. So basically, prostate cancer cells produce what's called blastic lesions, which induce production of bony disease, and it takes up that technetium-99 MDP. Cancer cells that, for instance, produce lytic lesions that don't have these sort of reparative bone formation don't take up the technetium-99. So it's not a very good test for cancer in the bone for some kinds of cancers. The prostate cancers happen to produce a lot of these these blastic lesions. So once deposited, the technetium gives off gamma rays and it's detected by a gamma camera. This is an example of a normal bone scan. This is an abnormal bone scan, so it's sort of lit up in this area. And the basic point, without getting into a lot of detail, is that for men with very high risk disease and or high PSAs, that's where the bone scans are more sensitive and specific. And I've listed the sensitivity and specificity generally in that range of 60 to 70%. Men with high PSA, high risk disease, and negative and positive predictive values in the 50 to 60% range, which isn't great. When you get to low risk disease, however, it becomes much less sensitive and specific. Other kinds of what I would call first generation imaging are you looking for prostate cancer, utilize choline, C11, FDG PET, sodium fluoride PET. And I'm not going to go into all of the sort of details of this, but the general problem with these tests is that they all mostly require aggressive prostate cancers in order to be able to take up the radiopharmaceutical, and they don't directly target the prostate cancer. So also some of these tests, many normal cells and benign processes like inflammation or infection can also take up these agents. And so they tend not to be very specific for prostate cancer. And then there are some insurance issues that I won't get into with some of these tests as well. Second generation radiopharmaceuticals, which we're going to kind of start, which I'm going to talk about, are mainly two kinds of scans. One is this F18 fluciclovine or Axemin scan, and then we'll talk about PSMA and PSMA scans. But just a few words on the Axemin scans. Basically, these were FDA approved in 2016. They're currently in Albuquerque since 2018 to 2019. They utilize the amino acid transporters. So cells that are rapidly dividing tend to take up these amino acids, and they take up that ligand that the radioactive F18 is attached to. And on the right, you can see this is just showing a pretreatment scan of a patient that got radiation Up at letter C was the pretreatment scan, which is a combination of the CT scan and then the detection of the beta rays. And after treatment, the patient was found to have increasing PSA. Another Axeman scan was taken. Here it shows uptake of the cancer. So before you had the cancer, now after you have the cancer, there was a lymph node as well that was biopsied, and you could see the biopsy specimen that proved that that Axeman scan did show that there was cancer within the prostate and within the lymph node. Axeman PET scans have been looked at in multiple prospective trials. They've compared them to Prostate scans, which nobody really uses anymore. They've compared them to sort of CT, bone scans, choline scans. The bottom line is that it seems to be comparable to choline scans, but certainly better than bone scans or CT scans. The indication for these for F18 is on biochemically recurrent or suspected recurrence of prostate cancer. And one study looked at the Axeman scans versus CT scans. And based on that, the CT scans, you can see the Axeman scans did a better job in kind of being showing with positive predictive values and negative predictive values. These are the Axeman results. These are the CT results. This to the right shows another scan. The important point here is this is just looking at positivity rate, not really the definitive gold standard of whether there's recurrence or not, but just looking at whether they show any, the Axeman scan shows any uptake on a biochemically recurrent prostate cancers. The Axemans in purple, CTs are in yellow. And the important point is you can see that the sensitivity increases with PSA. So you get a PSA of 2 to 5, and you have the highest rate of positivity. And some insurance companies say that you need to have a PSA of at least 2 in order to actually get an Axeman scan covered. But you can have lower PSAs, but the positivity, indirectly, the sensitivity decreases with PSA. Sorry, I'm looking at the time here. So there was an interesting trial, and I'm just going to briefly mention it, looking at these Axeman scans and comparing CT versus CT-directed scan versus an Axeman-directed radiation treatment following radical prostatectomy for recurrent cancers. The bottom line is that the Axeman scan showed distant disease and took some of those patients out of treatment so that they didn't get radiation treatment to the prostate bed. The Axeman scan sometimes showed lymph nodes, so that the treating physician then included lymph nodes in the treatment. And this particular study, which is unusual because it showed that an imaging study actually can improve event-free survival of men with prostate cancer. So now let's switch to PSMA. And so PSMA stands for prostate-specific membrane antigen. This is a cartoon of PSMA. This is the prostate cancer cell membrane. The PSMA is highly overexpressed in prostate cancers. It's several hundredfold less expressed in other tissues in the body, although some of the tissues that do take it up a little more are the lacrimal and salivary glands, and that has implications for the side effects of PSMA treated patients, and we'll talk about that a little bit. Was used in the past as a target with prostate scans, but with a different ligand, which wasn't very sensitive, excuse me, for prostate cancer. More than 80% of men with prostate cancer overexpress PSMA. The expression is independently correlated with the stage of the tumor, whether it's metastatic disease, risk of recurrence, the prognosis of the tumor as well. PSMA is a good imaging target due to its overexpression in malignant prostate cancers, and this is just a graph from a publication. Looking at benign tissues, there's very little expression of PSMA. In terms of just a localized prostate cancer, it increases, and then when you get to more aggressive metastatic disease, prostate cancer, you have the highest expressions. In a particular study, PSMA expression was inversely correlated with 5-year recurrence-free survival. So basically, those patients that have a no or low PSMA expression have high survival, Whereas if your prostate cancer cells show high PSMA expression, your survival is much reduced. So now let's just talk about PSMA second generation imaging studies, namely the gallium-68 PSMA-11 scans and the F-18 or PYLARIFY PSMA scans. The gallium scan was approved in 2020, not really commercially available yet. It is at UCLA and UCSF as main sites. It's mainly accelerator produced. It's harder to make than the F-18, which is used in typical PET scans. And so people have a lot more comfort with utilizing the F-18 radioactive element. And because of that, there's some studies done on the F-18 PYLARIFY PSMA, which did get FDA approval in 2020 and is becoming available now around the country. Hopefully here in Albuquerque and at our center, we'll be having them up and running, the F-18 PSMA, early next year. The short half-lives of both of these make it kind of difficult to produce and administer. You can see the F-18 is almost twice as long, has a half-life of gallium-68. So these things decay pretty quickly. So you've got to get them into the patients once you generate them. The indications for both gallium-68 and the F-18 are men with prostate cancer who have one suspected metastatic disease who are candidates for initial or definitive therapy, or two suspected recurrence based on elevated PSA. And if you just recall for the Hashemi scan, the indication for that was only on suspected recurrence, not on initial workup. And again, it's a little busy. I'm not going to kind of go through the two main trials that led to the FDA approval of gallium-68. But basically, they were comparing scans that were done initially to radical prostatectomies and then pelvic lymph node examination, which is sort of the gold standard to say, hey, so that gallium-68 scan showed that this left pelvic lymph node was hot. Was it really hot after the surgery was done? And the bottom line is that the sensitivity of the test was about close to 50%. Patient-specific positive predictive value was close to about 70% on that prospective trial. And it actually went up a bit on for higher Gleason score disease. Another prospective trial looked at biochemical recurrence. And there, the metrics were a little less of a gold standard. It was some got biopsies, some were just following with PSAs and got other imaging. So you saw sort of a lymph node that was enlarging. And then they said, yes, that means that the scan was predicting it, but they weren't all biopsy proven. But basically, the important point from that study was that the higher the PSA, the gallium scans did a better job of detecting patients, but are detecting disease recurrence. But even with PSAs between 0.5 and 1, when you start getting less than 0.5, it seems that the test has a little bit more difficulty. Also on that test, there were a number of positive biopsy patients that had negative scans. Not going to go really into too much. There was a meta-analysis done looking at a number of retrospective and prospective studies. There was a head-to-head study looking at PSMA versus Hashemi and biochemically recurrent scans. Again, a lot of these patients didn't necessarily get biopsies, so it was hard to compare it to a gold standard. But they seem to suggest that the gallium scans have a high sensitivity and specificity and a little higher per patient sensitivity as compared with the Hashemi scans. One trial called the Pro-PSMA, and I'm just going to show some images here. It looked at a number of men, and again, these are looking at two men, just as example, who had high PSAs. They were high risk, presumed localized disease. The CT scan showed that there was just localized disease, whereas the gallium PET scan showed uptake in that bone, and there was no corresponding uptake on the CT. Similarly, here in red, you can see metastatic disease detected on that gallium PSMA, whereas it wasn't on the other on the CT part of the scan. On the top here this is a pre-treatment scan where you can see the actual uptake on the PSMA scan, whereas on the CT scan, they wouldn't have called, the radiologist would not have called any disease there. Following treatment with hormones, those areas disappeared. And they basically found on this study that the PSMA PET scan was about, let's say 20, almost 30% had greater accuracy than a CT or bone scans. And again, there's another trial, I won't go through it, but just to say that the positive predictive and negative predictive values were around 80%. The sensitivity and what we've seen when you compare it to actual histopathology, the sensitivity of the study is about 50%. The specificity is higher. These are two trials looking at the F18 PSMA that led to its FDA approval recently. Again, sensitivity is in the 40 to 50% range, positive predictive, negative predictive values in the 80% range. Let me see how we're doing on time. So in summary, PSMA scans are currently the best we have. They seem to have a higher negative predictive value than a positive predictive value, meaning that if it's a negative test, you can feel comfortable that it's probably negative. Whereas if the scan shows something, while it's more likely than not that there's something there, there's still a significant risk that there will not be a corresponding finding, let's say, if you underwent a prostatectomy. There are studies looking at Axemin versus PSMA. There's a new radiohybrid PSMA ligand being evaluated in different trials. And in a recent NCCN footnote, they were recommending that actually for initial staging studies of prostate cancer, you just do a PSMA scan without the need for a CT or bone scan. And hopefully we'll see if Medicare or other insurances adopt that policy. So now let's spend the rest of the time just talking about radiopharmaceuticals in prostate cancer treatment. And in terms of progression of prostate cancer, a number of people have probably, a number of you participants have probably seen this. Basically, the disease starts out localized. If you fail, the PSA starts to rise. You're put on some sort of androgen deprivation therapy. Your PSA drops. Once your PSA starts rising on the androgen deprivation therapy, that's what the definition of castrate resistance is. And so when we talk about castrate-resistant prostate cancer, that's what we're talking about, rising PSA and or disease recurrence despite castrate levels of testosterone. Prostate cancer spreads to the bones. Approximately 90% of men with advanced disease do develop bone metastasis. Some of the original radiopharmaceuticals, strontium and samarium, and actually in some ways similar to radium, the Xofigo treatment mimics calcium. These are alkali earth metals. They substitute, the strontium and the radium substitute for calcium nearby prostate cancer cells that are inducing bone growth right next to the prostate. So these initial first generation treatments weren't directed specifically to the prostate cancer, but the areas right nearby prostate cancer. I'm not going to really talk much about it, but strontium and samarium, they're still used today, not very commonly. They do provide palliation of pain. They do not provide a survival benefit. A number of trials have looked at them with external beam radiation, with chemotherapy. Basically, it provides an additional 3 to 6 months of pain relief. There's improvement of quality of life with strontium or samarium. And it decreases the need for radiation. It delays new disease. There is some myelosuppression or drop in your blood counts with these two drugs. Typically, they recover by about 3 months of time. But again, there's no survival benefit with samarium or strontium. I'll really briefly talk about radium for a few minutes, and then we'll switch to the lutetium PSMA recently published VISION trial. I put a small cohort of patients on that trial, and we'll talk about a little bit of that. We'll review the published results from the New England Journal of Medicine publication, and we'll then briefly end with talking about some trials with ongoing PSMA targeted agents. Xofigo, again, it mimics calcium in those areas of blastic bone nearby the prostate cancer cells. It takes up the radium. It gives off alpha particles, which are, again, the most lethal form of DNA damage. Because of the short range of the alpha particle, they don't really, they have a very minimal effect on normal tissues, and the side effect profile is low. The radium decays to a stable form of radon in about 11 days. That's the half-life. The Alsimca trial was the main trial looking at men with symptomatic metastatic castration-resistant prostate cancer without visceral metastatic disease. It was randomized to Xofigo and best standard of care versus placebo and best standard of care. You receive 6 one-month injections. The primary endpoint was overall survival. And you can see on the main graph from the publication that led to its FDA approval, there's about a 3.6-month median survival improvement, or a 30% risk reduction in death compared to the best standard of care arm. Excuse me, at that time, the best standard of care arm was just first generation anti-androgens like bicalutamide or estrogens. When the trial came out, they did not have the enzalutamide or Zytiga at that point. Adverse reactions, again, grade 1 and 2 are very mild. Grade 3 and 4 may require medications or hospitalization. Grade 5 is death. As you can see, Xofigo is very comparative to just the placebo arm, which is really just the natural disease state of the developing metastatic prostate cancer. They're very low rates of nausea, diarrhea, and vomiting, which are the main side effects and are mild in most patients with Xofigo. Hematologic abnormalities, again, you can have drop in counts. You can have some anemia with the treatment, but it typically recovers by about a month's time. And low rates, again, of more serious side effects. You can't administer with chemotherapy. You can give it with external beam radiation. The survival benefit is independent of PSA levels. Again, the radium does not target the prostate cancer cells directly. It's excreted in stool, and about 2/3 of men do get pain relief in addition to the survival benefit with the drug. And it's a very safe treatment to handle, and for family members that are around those who are treated with the drug. You shouldn't administer it with abiraterone. A trial showed slight decrease in overall survival. However, with enzalutamide, recent update abstract presented at ASCO this year showed that you kind of have to add in a bone protective agent like Zometa or Xgeva, and then it looks like the outcomes are the same with very low rates of fractures, which is what was increased on the abiraterone arm. So enzalutamide and Xofigo can be given together as long as you give a bone protective agent. At our center, we have the DORA trial going on. That's for those patients that progress on androgen deprivation therapy. They're randomized to chemotherapy plus radium versus just chemotherapy alone. And we're currently putting patients on that on our study. Outside of the state, as far as I'm aware, there are people are looking at radium with immunotherapy, with PARP inhibitors, or with other disease states. I'm going to skip this. There's a very high unmet need for those patients that fail all of the standard therapies like enzalutamide, abiraterone, radium. These are all kind of category 1 treatments, docetaxel and cabazitaxel. In Europe, this was given for a number of years. The lutetium-177, PSMA-617, was given for compassionate use. They did see some efficacy, and that's what led to ultimately a phase 2 trial that we'll briefly talk about. How does lutetium work? So basically, this is the radiopharmaceutical, the lutetium radioactive element bound to the PSMA-617 ligand that binds to the PSMA receptor on the cell. It's internalized gives off the radiation, damaging the DNA of the cell and also nearby cells around it. The important point from this initial prospective trial, the first one, which was published in May of 2018, basically what they did is they refined the patient selection. So if you were a patient that had an FDG PET that showed that there was obvious cancer, let's say in the mediastinum here, but then you got a gallium PSMA scan and showed that there wasn't any uptake there, that would be a negative PSMA, and those patients were excluded on the trial. So they were self-selecting. Again, a majority of patients do express PSMA, probably on about 80 to 90%, but that 10 to 20% of patients they excluded to get better statistics for when to use this drug. Xerostomia, dry mouth, fatigue, and hematologic toxicities were the main side effects of the lutetium. Again, salivary glands have a little bit of an elevated PSMA receptors. So that's why you get this dry mouth. It's usually grade 1, 2, and reversible in most patients. That phase 2 trial led to the recently published VISION trial. And that was just published in New England Journal in June of 2021. I'm proud to have been one of the 42 US investigators on that trial. Internationally, there were 32 other European sites. I enrolled 11 patients from around the state of New Mexico. We're the only ones offering lutetium at that time. Those 831 ultimate patients who underwent randomization from October of 2018 through October of 2019, so for 1 year. For my patients, 5 of the 6 that went on to the lutetium arm had decreases in PSA. 2 of those 5 had actually more than an 80% reduction in PSA. At this point, which is now 2 to 3 years from initiation of the trial, all but 1 patient has expired of their disease. I'm not going to go into too much detail here, but the study design was patients had to have a positive gallium PSMA scan. They had to have previous chemotherapy, 1 or 2 lines of chemotherapy, and previous novel androgen axis therapies like Zytiga or enzalutamide. They were randomized to lutetium plus the best standard of care versus just best standard of care in a 2-to-1 randomization. The lutetium was typically given from 4 to 6 cycles, given every 6 weeks. The primary endpoint was relapse progression-free survival and overall survival. There are a number of secondary endpoints that I won't talk about. And there were other safety and quality of life things that I will recently mention as they have been updated. They've been published, at least in abstract form, at the ESMO meeting recently. So the best standard of care was hormonal agents, older agents, ketoconazole, estrogens, things like finasteride. You can get radiation in terms of external beam. You cannot have any myelosuppressive agents on the best standard of care arm, like let's say radium or chemotherapy. And that was one of the complaints of the trial, that because chemotherapy is sometimes a best standard of care. But barring that issue, the results, the published results show that the overall survival was improved by about 4 months on the lutetium arm. This is again the best standard of care arm, and this is lutetium plus the best standard of care. They had a number of subgroups that they looked at. Basically, the drug is better. You want to give it with better performance status patients, lower performance status patients. Patients with liver mets maybe didn't benefit as much with the lutetium. And of course, there are only small amounts of African American, Black, or Asian people on the trial. And so I think that's just a statistical aberration just based on those low numbers. The other endpoint was looking at radiographic progression-free survival. Were there changes in the bone scan or CT scans? We didn't get PSMA scans after the initial entrance onto the study. But we got very frequent bone scans and CT scans on follow-up for these patients. And basically what it showed is about a 5.3-month if you will, improvement in lack of progression on the scans. So that's just showing again radiographically that the lutetium kind of prevents new metastases to form. Again, on the subgroups, it was generally the lutetium generally impacted all of the same subgroups as on the overall survival. Some secondary endpoints. This is looking at the response rates on some of those imaging on the bone scan and CT scans. And the bottom line is that 10% of patients on lutetium arm had a complete response on their imaging. About 40% had a partial response, so about a 50% response rate on the imaging. Whereas on the standard of care arm, as you would imagine, they either stayed stable or they progressed. On the right, this is a waterfall plot showing PSMA. On the lutetium arm, more than 50% of patients had a greater than 50% reduction in their PSA, and about a third of patients had a greater than 80% reduction in their PSA. Treatment side effects: fatigue, bone marrow suppression, and dry mouth. They were all reasonably low grade. Higher grades were more concentrated in the bone marrow suppression. On both the lutetium and standard of care, about 3% of patients died from the treatment. An ad hoc analysis looked at symptomatic skeletal events. So lutetium improved the time to first symptomatic event or death by 5 points. What is that? Like basically about 5 months. And so what that translated to was improved quality of life scores and decreased pain scores for those patients that had lutetium. Another trial that was just published prior to that directly compared lutetium to cabazitaxel chemotherapy for men, again, who failed docetaxel and all of the other therapies prior. The bottom line from that trial was that lutetium had more favorable and more frequent PSA responses than chemotherapy and had less grade 4 adverse events than chemotherapy. Currently, there are two trials that at our cancer center that we'll be offering and will be scheduled to open the next couple of months, beginning the new year. The first trial is a SPLASH trial, and this is basically moving lutetium a little bit earlier into the men with metastatic castration-resistant prostate cancer. So those men had to have progressed on at least one of the novel anti-androgen agents like Zytiga, but have not seen any chemotherapy. So those men are randomized to lutetium plus continuation of the androgen deprivation therapy. On alliance trial, 4% that were actually diagnosed with metastatic disease or progressed after local treatment with surgery or radiation. Let's see. And so those are the two trials that we'll be offering in the new year that are kind of moving lutetium down earlier. The FDA approval for lutetium is anticipated by the Novartis, the drug company that's making it, in March of 2022. So I anticipate being able to provide lutetium to patients off of studies in April of next year. The FDA approval will probably require a positive PSMA PET scan, which again, I hope to be able to be doing in the new year. And that can be both gallium or F18. And these men had to have metastatic castration-resistant prostate cancer. Again, you have to have failed the androgen deprivation therapy and at least one cycle of chemotherapy. Other trials outside of New Mexico, they're looking at immunotherapy with lutetium. There are some newer radiopharmaceuticals looking at actinium or thorium, which are alpha-emitting radiopharmaceuticals, more like the radium. Again, the lutetium is a beta emitter. New ligands are being investigated, new other PSMA ligands as well. So thank you very much. In summary, a lot of exciting developments within the radiopharmaceutical space. Thank you.
So I'm just going to ask this question. is how did gallium or F18 PSMA PET scans compare with C11 choline PET scans?
You know, I don't know that there's any of those studies. The only thing that I could find is, again, I'm not a radiologist, radiation oncologist, but the only, I would say, important non-retrospective studies did not compare that. But the Axeman scans did compare it with choline C11. The main problem with choline, and the reason why that's a very limited use imaging agent, is that the half-life is 20 minutes. So you literally have to produce it and give it. And and it doesn't, again, directly target the prostate cancer. What it targets is the choline, which is used, choline pathway, which is used preferentially, which is upregulated in prostate cancer cell derived metastasis. So it seems to concentrate more in that. So all I'll say is it hasn't been compared as far as I can tell to gallium, but it has been compared to Axeman, and it's pretty similar to Axeman. But I just think actually getting the choline is a very difficult. That's why it's very limited in terms of places that offer it. I don't know if that helped too much, but I haven't seen anything other than maybe some smaller retrospective studies looking at that.
Okay, I just have a couple of other real quick ones here. PSMA scan only uses PSMA 617 lichen. Can that scan be combined with spot radiation?
Let me maybe rephrase that question a little bit. Is the question, so the PSMA scan will kind of show us where let's say a metastatic disease is. And I guess the question is, can you then use stereotactic, let's say, radiation therapy to ablate that area of metastatic disease? And absolutely. And I'm sure that will be utilized. That's, I think we talked about, I think the previous speaker was talking a little bit about that in the context of immunotherapy. But for some, and I'll just kind of generally say for some sites, it seems that stereotactic radiation.
Oh. We lost our connection here.
Static sites. Sorry, can you hear me? Hello?
Yeah, we lost you for about
sorry.
5 seconds there.
I got you. The bottom line is for some sites, it's like in lung cancer, it's showing that it can provide a survival benefit, knowing where you're going to treat a metastatic site. You can only do it with a relatively small number of metastatic sites. It's being looked at in all kinds of different cancer types to see whether there is a survival benefit with stereotactic radiation.
Okay, and the last question here, and let you get going too. Can the PSMA treatment be given on a continuous basis? In other words, is there an advantage to continual treatment?
Well, sorry.
Okay, I'm sorry.
What was the question?
Can the PSMA treatment be given on a continuous basis? In other words, is there an advantage to continuing treatments with it?
Well, the trial was only for 4 to 6 cycles of giving the lutetium PSMA treatment, and that was given every 6 weeks. So, I think, at least in terms of the FDA approval, we're talking about 6 infusions, very kind of the same as with radium. Whether, once it gets FDA approved, people can try, I'm sure people will start looking at rechallenging patients, again, with either longer, more than 6 infusions, or maybe down the road, rechallenging those patients that seem to have response with lutetium again. So I'm not sure if I say it right, but I think 6 cycles is the maximum number of cycles that was given on the trial, and that's the maximum number that we know has benefit we don't know doing more has more benefit.
Okay, and I've got one last question, and then I'm going to have to move
Sure.
on. It seems that lutetium PSMA treatment would also work for still localized prostate cancer. Why is this apparently not being studied at this time?
Well, like everything else, we kind of everything moves down from those patients that, are not doing well, who have very advanced cancer. And like I mentioned, we have a couple of trials coming up that are moving it in a little bit earlier phase of metastatic disease. I anticipate that it may very well be being looked at in earlier, kind of earlier and earlier sites of disease. We are looking at, in men with high risk localized prostate cancer, looking at, we have another trial that's coming up with men who have high risk metastatic disease, and we're, instead of utilizing bicalutamide with Lupron for those men initially diagnosed with high risk disease, we're doing darolutamide and Lupron. So all of these drugs, whether it's androgen deprivation therapy or lutetium or chemo, they all eventually make their way down, but it's going to take some time.
Okay. Well, thank you so much, Doctor, for taking time out of your weekend. And we just want to thank you again that it'll take us a little while to absorb all the information, and we did record this. So if we need to go back and watch it over and over and over again, we can do that. So thank you so much.
Pleasure.
Okay, and I just have a few closing remarks here. Thank you for all who stayed with us through to the end. I know it was a long day, especially sitting in front of a computer. We would have preferred to do this live like we've done in years past, but with the pandemic and venues not being available, it just